many of the things that I want to talk about, assuming the pitch comes back, are to do with the technicalities of why the veins do what they do. The simplest bit is that the types of vein that we come across in the leg are deep veins, superficial veins, and perforating veins. And I think we've talked a lot already about that today. So the deep veins are the ones that lie under the muscle fascia and are the things which some people get excited about bringing back to life after deep vein thrombosis. The superficial veins are the things that I fill up with foam or sometimes laser, and different people have different opinions as to how the superficial venous incompetence should be treated. There are many different ways of doing it. Each has its own particular spectrum of adverse events that occur afterwards. And then there are the perforating veins. And earlier today, Jonathan Earnshaw said he doesn't bother too much with perforating veins, but at lunchtime I was demonstrating that actually our patient, who had lots of varicose veins on the outside of her leg, had one nice perforating vein on the outside of her leg, which was filling up those varices. So I did treat the perforator as a primary treatment. So the superficial veins that we know and love, the great venous vein that starts here at the medial malleolus, goes up behind the knee and then up to the groin. The small saphenous vein at the lateral malleolus and goes up at the back of the calf. And those are the major veins that we treat, deep veins. There's a femoral vein that we treat from time to time. And the perforating veins, well, actually, there are lots and lots of perforating veins. The one in Steve's photograph, to my amazement, people with resistant patches over the lateral aspect of the calf, resistant patches of thread veins, commonly have a little perforating vein underneath them, where the artery and the vein that provide blood supply to the skin have come out through the fascia and go straight up to the skin. And for some reason, that seems to give rise to a patch of thread veins in susceptible people. And just like Steve, I inject that vein, usually under ultrasound guidance. And I do what Steve does, inject it superficially, keeping away from the fascia where the artery is, because it's not a good idea to inject the artery, as Steve was suggesting. So we normally look at veins these days under ultrasound imaging, and there has been a bit of a change in the view in the way in which venous anatomy is described, because of what you see on the ultrasound machine, which gives a much better representation in life than does do X-rays. So here is the muscle fascia in the calf. This is a small saphenous vein lying in a little elliptical fascial space. And similarly, this is the great saphenous vein in the thigh lying in its fascial space. So there's the fascial space and there's the vein. And when I was doing my demonstration earlier on, the patient also had great saphenous vein incompetence, and she had veins that were lying inside this fascial space, which I cannulated, and she also had veins lying up here, the superficial accessory veins and tributaries, which I injected directly with a needle. So all of those veins contribute to the development of varicose veins. All of them, in my view, need to be treated. If you only, say, laser this vein, the superficially lying accessory veins tend to come back and haunt you after a relatively short period of time as brand new varicose veins. So this led to the description by Alberto Coggiati and Stefano Ricci of ultrasound anatomy. So there's the muscle fascia. Here is the main artery and vein, the femoral artery and vein in the limb, and the deep femoral artery. There's the saphenous vein, great saphenous vein, lying in its fascial compartment. That's the saphenous fascia. And that's the bottom bit, which is the muscle fascia. And then here are the accessory veins lying more superficially. So this arrangement, or at least the vein in the middle of the saphenous compartment, is described as the saphenous eye. This led to, or this realization that veins weren't all we thought they were before we started looking at them with ultrasound imaging led to this consensus, which was concluded in Rome at a International Union of Phlebology meeting, which concluded on the 11th of September 2001, which you will recall is a rather special date. We came back to our hotels to see pictures of aeroplanes crashing into buildings, much to our amazement. Well, this is the bit that you sink your needle into. So they're the telangiectasies, and there's a little reticular vein. There's a diagram similar to the one we've just been looking at. That's the muscle fascia with a femoral artery and vein in it. There's the saphenous vein lying in its saphenous compartment, and there's the accessory veins. So the telangiectasies and reticular veins all occur up here at the top. These things are the fat domes going into the reticular dermis, and up the top here is the epidermis, where the top part of the dermis, the papillary dermis, is located. So that's the top part of the dermis, the papillary dermis, and this is the rest of it, the reticular dermis, and then the fat in the fat domes underneath. And so those are the blood vessels running along underneath the skin, which we see and treat as reticular veins. Up here, there are a couple of venous plexuses, a deeper plexus and a more superficial plexus, and they join onto this lot, which are the capillaries that provide nutrition to the skin. So this bit above the wiggly line is the epidermis. And so there's a little arteriole feeding the capillaries in the skin. And this is the bit that once upon a time I used to look at with a capillary microscope, and we used to draw all sorts of interesting conclusions from what we could see going on up here, particularly in connection with the development of venous ulcers. So when we get telangiectasies, they are arising from these plexuses in the more superficial part of the dermis. So here we're injecting these things. If we're injecting reticular veins, then we're injecting these things underneath. Perhaps a significant consideration is that, of course, there are the arteries as well, and more arteries up here. So when you inject the skin, you have the problem that you're pretty clear to the arteries. But I think the arteries are very small and the veins very extensive in comparison. So the venous network is absolutely huge, and it's intended there for thermoregulatory purposes. But there are still rather fine arteries, and if you happen to inject those, you get an injection ulcer that Steve was mentioning a moment ago. If you get something a bit bigger down here, inadvertently hit this artery, you get embolia cutis medicamentosa, which looks like this. Somewhere, there we go. And it evolves. And it's also known as Nicolau syndrome, which is what you get when you're doing an intramuscular injection and you forget to aspirate on the syringe before injecting whatever it was you're injecting. So that's basically a chemical vasculitis which occurs within a few hours of injection normally, and evolves over a few weeks or several weeks, depending upon how lucky you are. And if you want to know how to treat it, there's an article by the guy from Australia, whose name escapes me at the moment, in Phlebology a few weeks back, and he says you should treat with high-dose steroids, 30 milligrams of prednisone a day for a week or two or three. And I think you also ought to treat with anticoagulant treatment as well, which was one of the earlier treatments described for this. But the main thing is you don't really want to see that, so Steve gave some ideas about how you should avoid it. One of the things I think you should do is, in fact, not to inject more than 1/4 ml or at most 1/2 ml of sclerosant in any one place, because you'll still get it if you're in the artery, but it would be much milder than if you put 1, 2, 3 mils in. One of my chums, well, no, an acquaintance of mine, steamed up to me at a meeting and said, look, I got a patient and he got this Nicolau syndrome thing. And I said, well, oh, what were you injecting? A reticular vein, a little reticular vein near the knee? And so what did you inject? Well, I put 5 mils of 0.2% STS into it. And I said, 5 mils, have you not read the SPC for Fibrovane? It says not more than 1 mil, if I remember rightly. And so what he'd done is he injected the right stuff in the right vein, but vastly too much. And if you do that, you do get something similar to this. And if you're very unlucky, the skin falls off and you get a big hole in the leg and a big bill from the solicitor. We heard earlier on, Judy Ulstock was mentioning that they do quite a lot of injecting into the sub-ulcer veins, which brings in the question of what is happening in all the valves, in all these little veins that we're injecting. We think we have to inject feeding veins. Well, why is that? And some information that Andre van Rij from New Zealand investigated with the help of his research chap is whether or not these valves in the superficial veins in the skin are competent or not. So what they did was take amputated legs, already a lovely gruesome study, and they did retrograde venography corrosion casting. So they injected a contrast medium that would remain after the rest of the limb had been etched away in acid. And they did it in 15 limbs altogether, 8 with varicose veins and 7 without. And these are the pictures that they came up with. So this is in the top picture, a little vein in the skin, and the points that they're marking there are the places where competent valves have prevented reverse flow. But in another bit of another leg, then some of the valves weren't working and they got a bit more backflow and a bit more black flow, and these things are the telangiectasias, and many telangiectasias and huge numbers of telangiectasias in some people, and this is supposed to be from normal limbs. Well, normal was that the saphenous veins were competent in these patients. So basically, when you inject into a little blue vein in the skin, you do get reverse flow into the superficial veins. And as I was saying earlier on, if you inject enough sclerosant into the superficial veins, you can destroy the skin with Nicolau syndrome. And when the picture comes back, we can look at what happens in leg ulcers. So this is the leg ulcer, and this is after it's, the specimen has been filled with the blue dye in the veins. And if you look at the corrosion cast, which is this, the ulcer contains vast, or the peri-ulcer skin contains vast numbers of little veins, and they're all incompetent. The valves are just not working. So you can inject underneath the ulcer into the slightly larger veins if you're bold and have an ultrasound machine, and fill all these with sclerosant, which some people say is a good idea. But again, I think you have to be careful how much sclerosant you put in, because I've certainly made people a bit worse by doing exactly that. And but in the longer term, it has been beneficial. The ulcers did heal. So there are many interesting things happen in the anatomy of veins which bear quite a lot on what we do in clinical practice. Thank you very much.